Drug-resistant tuberculosis must be presumed or suspected in persons who remain bacteriologically positive, either smear positive, culture positive, or gene expert positive after intensive phase of standard first-line TB treatment with or without clinical improvement. So persons who test rifampicin resistance positive at initial diagnosis with gene experts must also be treated as cases of drug-resistant tuberculosis. And these persons must be further evaluated using TB culture and drug susceptibility testing or newer molecular diagnostic tests such as line probe assays. So persons at high risk of drug resistance are TB patients failing category 1 and category 3 or category 2 treatment, contacts of confirmed drug resistant tuberculosis patients, and TB HIV co-infected patients not improving on treatment. The persons at minimum risk of drug resistance are relapsed TB patients, return after loss to follow-up, and health workers newly diagnosed with TB. Patients are classified according to the pattern of documented drug resistance profile. The drug regimen for treatment is selected based on the following principles. So, history of drugs used to treat TB patients, profile of drug resistance, and or DST profile on the patient, and a minimum of 4 new core medicines that are known to be effective. Kanamycin or capreomycin is an injectable medicine, is the backbone of the 4 core medicines and should be used in the intensive phase. An effective fluoroquinolone should be used due to the extensive use of earlier generation fluoroquinolones. May include a first-line drug to which the strain is susceptible. Cross-resistance may occur between drugs of the same group, and this is taken into consideration. Drugs are administered daily under strict DOT throughout the injectable and continuation phases. Treatment of multi-drug resistance TB and rifampicin resistance TB drugs and patients is prioritized. Treatment duration is 20 to 24 months and is determined by sputum smear and culture as bacteriological conversion. Treatment lasts 16 to 18 months after bacteriological conversion, and progression from initial to continuation phase is dependent on at least 4 consecutive months of negative sputum cultures. Community-based care is promoted over facility-based care, except in situations requiring admission for management of complications. The practice of infection prevention and control should be maintained at all times during treatment of these patients. The treatment adherence is critical in the treatment of drug-resistant tuberculosis due to limited number of available effective medicines. The treatment is challenging due to long duration, drug toxicities, and side effects. And clinical teams must use a patient-centered care approach and support patients throughout treatment until cured. Psychosocial and economic support is required for treatment supporters, patients, families, and clinical teams throughout treatment, and early detection and prompt management of drug side effects ensure successful outcomes. Pharmacological treatment. Treatment of multi-drug resistant TB as MDR-TB and rifampicin-resistant TB as RR-TB patient is prioritized. And the treatment duration is 20 to 24 months and is determined by sputum smear and culture as bacteriological conversion. The treatment lasts 16 to 18 months after bacteriological conversion, and the progression from initial to continuation phase is dependent on at least 4 consecutive months of negative sputum cultures. A second line treatment for multi-drug resistance TB. Let's look at the TB treatment category, TB patient type, treatment regimen, the comments. So for both adults and children, the initial phase and the continuation phase. For multi-drug resistant tuberculosis, all newly diagnosed MDR-TB with or without HIV and symptomatic contacts of confirmed multi-drug resistant tuberculosis with or without HIV. The initial phase has 8 months of CM, LFX, PTO as CS number PAS. So Z stands for pyrazinamide, and KM stands for kanamycin. CM stands for carpromycin. LFX stands for levofloxacin. ETO stands for ethionamide, and PTO stands for prothionamide, and CS stands for cycloserine, and PAS stands for para-aminosalicylic acid. Okay, so for the continuation phase for multi-drug resistant tuberculosis, 12 months of a combination of Z, LFX, PTO, and CX number PAS. So or hash PS. So the hash means for every 250 milligrams of cycloserine as a CS, you give 50 milligrams of pyridoxine as vitamin B6 to prevent peripheral neuropathy, and the dose of pyridoxine should be doubled in HIV patients. The PAS is an alternative to CS, that's a cycloserine. The treatment is daily, and the treatment month is 28 days. So you modify treatment according to culture results. So let's look at the treatment protocol for other resistant types. So we look at resistance pattern, a TB patient type, treatment regimen, comments. So adults and children, the initial phase and the continuation phase. So for streptomycin resistant, mono-resistant patients as a TB patient type, initial phase is 2 months of HRZE, and as you know, H is isoniazide, rifampicin is R, pyrazinamide is Z, ethambutol is E, and S is streptomycin. So the streptomycin resistant, and the initial phase is 2 months of HRZE, and continuation phase 4 months of HR. Ethambutol resistant, the TB patient type, mono-resistant, the initial phase 3 months of HRZ, continuation phase 6 months of HR. For isoniazid resistant, as mono-resistant, the initial phase and continuation phase is 9 months of HRZE. And the comments, you add extra dose of isoniazide up to a maximum of 300 milligrams daily for treatment duration. For streptomycin and isoniazide resistance as polyresistant TB, both initial and continuation phase is 9 months of HRZE. You add extra dose of isoniazide up to a maximum of 300 milligrams daily for treatment duration. or isoniazid and ethambutol resistant or poly-resistant TB for initial and continuation phase, 9 months of RZLFX. And the comments, we extend treatment to 12 months if extensive lung destruction form. And you detect this in X-ray image. Okay, so let's look at there is another resistance pattern. So for HE and S plus or minus Z, that's polyresistant TB. Initial phase 3 months of KM, PTO, LFX, R and Z, and continuation phase 18 months of PTO, LFX, R and Z. So the comments, modified MDR regimen plus R. So R mono or polyresistance as rifampicin resistant TB. Initial phase 8 months of HZCM, LFX, PTO, and CX or PAS. So the PAS is alternative to CS. And in the continuation phase, 12 months of HZ, LFX, PTO, CS, and PAS. A full MDR regimen plus H. So let's look at some few definitions. So mono-resistant TB. The TB bacilli have resistance to only one of the first-line anti-tuberculosis medicines. So streptomycin, isoniazid, rifampicin, pyrazinamide, or ethambutol. And polyresistant, as TB bacilli have resistance to at least 2 medicines, but not to both isoniazid and rifampicin. And rifampicin resistance as RRTB. TB bacilli have resistance to rifampicin with or without resistance to other first-line anti-tuberculosis medicines. This may be mono, poly, multi, or extensively drug-resistant TB. Multi-drug resistant TB. And TB bacilli have resistance to at least both rifampicin and isoniazid. Extensively drug resistant as XDR TB. And the TB bacilli have resistance to one of the fluoroquinolones and at least one of the 3 injectable second-line drugs, kanamycin, capreomycin, or amikacin, in addition to MDR, multi-drug resistance TB. The dosing of second-line medicines. So let's look at the anti-TB drug, the abbreviation, recommended daily dosage, and maximum dose, and adult dosing and children dosing. So pyrazinamide, that's the Z. The adult dosing is 20 to 30 milligrams per kilogram once daily with a maximum of 2,000 milligrams, and children dosing 30 to 40 milligrams per kilogram once daily, 2,000 milligrams. Kanamycin, abbreviated as KM. In adults, you give 15 to 20 milligrams per kilogram once daily with a maximum dosage of 1,000 milligrams. In children, 15 to 30 milligrams per kilogram once daily, the maximum dosage of 1,000 milligrams. And capreomycin and CM, adults 15 to 20 milligrams per kilogram once daily, 1,000 milligrams maximum. In children, 15 to 30 milligrams per kilogram once daily, the maximum dosage of 1,000 milligrams. And levofloxacin, abbreviated as LFX, adults 750 to 1,000 milligrams once daily with a maximum dosage of 1,000 milligrams. In children, dosing 15 to 20 milligrams per kilogram per day in 2 divided doses with a maximum dosage of 1,000 milligrams. Ethionamide, as ATO, The adult dosing is 500 to 750 milligrams daily in two divided doses. The maximum dosage of 1000 milligrams. In children, 15 to 20 milligrams per kilogram per day in two divided doses. The maximum dosage of 1000 milligrams. And prothionamide as PTO, adult dosing 500 to 750 milligrams daily in two divided doses, and 1000 milligrams maximum. In children, 15 to 20 milligrams per kilogram daily in two divided doses with a maximum dosage of 1000 milligrams. And cycloserine, that's CS, abbreviated as CS. The adult dosing is 500 to 750 milligrams daily in two divided doses with a maximum dosage of 1000 milligrams. In children, 10 to 20 milligrams per kilogram per day in two divided doses with a maximum dosage of 1000 milligrams. Or para-aminosalicylate acid as PAS. In adults, it's 8 grams once daily or in two divided doses, 12 grams maximum. In children, you give 200 to 300 milligrams per kilogram per day in 2 to 3 divided doses with a maximum dosage of 8 grams. Very soon, shorter treatment regime will be adopted for 9 to 12 months for the management of drug-resistant TB. So the national TB control program should be checked regularly. Referral criteria: so refer all patients to DOTS treatment center for management and monitoring under the National Tuberculosis program.